Welcome to the Hospital Medicine Unplugged podcast. Today, we're doing a deep dive into one of the most challenging and high-stakes scenarios we face on the wards. Resistant hypertension. It's a condition that really forces you to be methodical, part detective, part, pharmacologist.
It's such a critical topic. The scope is just massive.
Yeah.
We're talking about resistant hypertension affecting what? Somewhere between 8.5% and maybe up to 20% of all hypertensive adults in the U.S. It's not just a label. It's a huge risk accelerator.
The data is really sobering when you look at it. I mean, these patients face at least a 50% higher risk of MI, stroke, end-stage kidney disease, and cardiovascular death compared to patients with non-resistant hypertension.
Exactly. That kind of risk disparity means a superficial approach just won't cut it. You have to be exhaustive.
And that urgency gets even more intense in the hospital, right? A patient comes in, their pressure is sky high, and you have to immediately figure out, what am I looking at here?
That's the core question. Is this chronic true resistance that needs a whole new long-term strategy? Or is this just acutely uncontrolled hypertension from pain or stress, or because they missed their meds on the way to the hospital?
Right, or their volume status is just completely off.
And if you mix those two scenarios up, you can cause real harm.
So our mission for this deep dive is to give you a systematic, evidence-based roadmap. We're pulling from the latest 2025 AHADCC guidelines and recent trial data to help you confidently diagnose true resistance, rule out all the mimics, and really optimize their regimen before they leave.
Okay, so let's start with the basics. We have to be really precise with the definitions.
So let's lock it down. What exactly is resistant hypertension, or RH?
According to the ACC-AHA, it's defined in two ways. First, it's a blood pressure that's still above goal, and that goal is typically less than 130/80, even though the patient is on 3 different antihypertensive meds.
And these can't just be any 3 meds, right?
No, they have to have complementary mechanisms. And critically, one of them has to be a diuretic at the maximally tolerated dose.
That maximally tolerated diuretic piece is so important and so often overlooked. So what's the second part of the definition?
The second part covers the patients who look like they're controlled. RH also includes patients whose blood pressure is at goal, but it takes 4 or more medications to get them there.
So if you need that much firepower just to hit a 130/80, by definition, you're resistant.
You are.
I think it's also really helpful to contrast RH with a couple of other subtypes. It helps guide treatment. We know RH is mostly about volume overload and aldosterone excess. What about the others?
Okay, so next up is refractory hypertension. This is, the really, really tough group. It's maybe 10% of all RH cases.
And the definition.
It's blood pressure that's still uncontrolled even on 5 or more agents. And that regimen has to include both a diuretic and a mineralocorticoid receptor antagonist, an MRA. If you fail an MRA and you're still not at goal, you are refractory.
And that's where the pathophysiology really shifts. RH is volume-driven, but refractory hypertension is dominated by this just overwhelming sympathetic nervous system activity.
Precisely. The standard treatments aren't working because you're dealing with a massive neurohormonal drive.
And then the third one is malignant hypertension,
which is a completely different beast. It's a pure acute crisis. We're talking severe hypertension, maybe over 180 systolic, with acute end organ damage. That's a hypertensive emergency, and it demands IV therapy, which we'll get into later.
Okay, so who gets RH? The risk factors seem to cluster around cardiometabolic and renal issues.
They do. Older age, obesity, chronic kidney disease, diabetes, those are the big ones.
And there's a really important health equity piece here, too. The sources point out that RH is more common in Black populations.
That's right, and it's often tied to adverse social factors. Things like living in disadvantaged neighborhoods, which can create barriers to consistent care, and that can lead to what we call clinical inertia.
Meaning delays in diagnosis or not titrating therapy aggressively enough.
Exactly. And that's why we have to be so proactive. When you look at the prognosis, you really see the stakes. You mentioned the 50% increased risk, but over 10 years, the cumulative cardiovascular event rate for true RH patients is around 35%.
35%. And compare that to someone with white coat-resistant hypertension.
It's only 14% for them. That huge gap is exactly why we have to be so good at telling them apart. You don't want to be escalating therapy and adding side effects for a patient whose actual risk is much, much lower.
That 35% number really sticks with you. And it brings us to what is probably the single most important step in the hospital, ruling out pseudoresistance.
This just can't be overstated. The data suggests that only about 10 to 15% of patients who look like they have RH actually do.
So the vast majority don't.
The vast majority. Maybe up to half of it is just due to things we can fix. Poor adherence, too much salt in their diet, or we're just not measuring the blood pressure correctly.
So the ACC-AHA gives us 5 big categories of pseudoresistance to work through. Let's start at the very beginning. Accurate blood pressure measurement.
Right. If your input is flawed, the whole diagnostic process is flawed. You have to be a stickler for technique. The patient should be seated, feet on the floor, back supported, arm at heart level.
And they need to have rested quietly for at least 5 minutes. No talking.
No talking. And in the hospital, this is a huge challenge. We have different machines, rotating staff, and measurements are often rushed during rounds when the patient is in pain or anxious.
You mentioned technique. What are the most common errors you see?
The wrong cuff size is probably number one, especially with the rates of obesity. Using a regular adult cuff on a large arm can artificially inflate the systolic reading by 10, 20, even 50 millimeters of mercury.
50? That's unbelievable. You could be treating a hypertensive emergency that doesn't even exist.
It happens all the time. And you also have to think about device calibration, especially with automated machines that are sensitive to movement.
Okay, so number 2 on the list of mimics is white coat-resistant hypertension. How do we even begin to sort that out in an inpatient setting?
Well, the definition is an office BP that's above goal. But their out-of-office BP is actually normal. And we care because out-of-office measurements, like from ambulatory blood pressure monitoring or ABPM, are much better predictors of cardiovascular events.
Someone with white coat hypertension has a risk profile that's closer to normal, not sustained hypertension.
Exactly. And in the hospital, you have to assume that the white coat effect is amplified. The stress of being sick, the pain, the constant checks, it all drives the pressure up.
So what can we do? ABPM isn't really practical for most inpatients.
It's not. So you have to rely on other clues. If they have meticulous home BP logs, that's gold. Otherwise, when you're titrating meds, you should try to get measurements when the patient is calm, their pain is controlled, and maybe use an automated machine to take several readings when no one is in the room.
Okay, that makes sense. The third cause, and this is a huge one, is medication non-adherence.
It's the #1 reason for acute severe hypertension. It probably accounts for 30 to 50% of all apparent resistance cases.
And it's not always intentional. It could be cost or the regimen is just too complicated.
Right. But we as hospitalists can actually make the problem worse during the admission.
How so?
Well, studies show that something like 41% of patients might not get their home meds during their hospital stay because of reconciliation delays. Even worse, about a quarter of post-op patients just weren't restarted on their home antihypertensives at all.
And then you have formulary restrictions forcing substitutions that aren't really equivalent.
Exactly. You inadvertently disrupt a regimen that was actually working for them.
So simply asking, are you taking your meds, isn't enough. We know that's unreliable.
Totally unreliable.
Yeah.
You need to be a detective. That means a careful med rec, checking the administration records during their stay, and if you can, look at pharmacy refill records. If you see a 3-month prescription that was last filled 6 months ago, you found your problem.
Okay. Number 4 is interfering medications or substances.
Yeah, and this is everywhere. About 20% of adults with hypertension use over-the-counter meds that can interfere. The big ones are the NSAIDs, the non-steroidal anti-inflammatory drugs. They cause sodium and water retention and basically fight against what diuretics and ACE inhibitors are trying to do.
And in the hospital, that list gets a lot longer.
It does. You have to look for corticosteroids, which we use all the time, sympathomimetics, calcineurin inhibitors for transplant patients, erythropoietin for CKD, and even some cancer drugs like VEGF targeting agents. Finding one of these should make you immediately question if the resistance is real.
So you have to address the offending agent. Either stop it or find a way to counteract its effect.
You have to.
Okay, the 5th and final category of pseudoresistance is a suboptimal treatment regimen. The right idea, but the wrong execution.
This is usually about dosing. Either the dose is too low, the interval is wrong, or, and this is a critical mistake, the diuretic class doesn't match the patient's kidney function.
This is the EGFR threshold rule.
Yes. Everyone needs to know this. Standard thiazide diuretics, like hydrochlorothiazide, they just stop working effectively when the EGFR drops below about 40 to 45.
Why is that?
It's because they work in the distal convoluted tubule. As kidney function gets worse, not enough of the drug actually gets to that target site to have an effect.
Yeah.
So the patient becomes volume expanded.
So what's the fix?
Below that EGFR threshold, you have to switch them to a loop diuretic. something like furosemide, usually dosed twice a day to get adequate volume control. Not making that switch is a classic cause of pseudoresistance.
So once we've done all that, we've corrected the technique, confirmed the elevation, checked adherence, stopped interfering drugs, and optimized the diuretic, then we can start to feel confident we're dealing with true resistant hypertension.
And that's when we can really focus on the underlying pathophysiology, which is all about volume overload and aldosterone excess.
Right, and knowing that core mechanism is what's going to drive our drug choices later on. It's not just salt retention. Aldosterone itself promotes inflammation, fibrosis, and vascular stiffness.
It's a vicious cycle. And that's why MRA agents are so effective as a fourth-line therapy. It directly targets the problem.
And just to recap, this volume and aldosterone-driven mechanism is what separates RH from that refractory group, which is all about sympathetic hyperactivity.
Exactly. So once we've confirmed true RH, the next step is to screen for secondary causes. They're much more common in this group and require very specific management.
Okay, let's go through the big ones. First up, primary aldosteronism, or PA.
PA is the most common endocrine cause. It's found in anywhere from 5 to 25% of RH patients, so you have to have a high index of suspicion.
Who should we be screening?
Any patient with resistant hypertension. Definitely anyone with hypertension and hypokalemia. But you have to remember that most PA patients, maybe 50 to 80%, do not have hypokalemia, so you can't rely on that. You also screen for an incidental adrenal mass, or if they have coexisting obstructive sleep apnea.
And the test is the aldosterone to renin ratio.
Right. You're looking for a suppressed renin, usually less than 1, with a non-suppressed aldosterone. A ratio of 30 or higher is generally considered positive and needs a confirmation test.
But the challenge, especially for us in the hospital, is all the drug interference.
It's a huge problem. Ideally, you need to stop spironolactone and eplerenone for 4 weeks before the test. ACE inhibitors, ARBs, beta blockers, they all interfere. It's often impossible to do that safely during an acute admission.
So the goal in the hospital is to recognize the possibility and make a plan for outpatient testing, maybe by switching them to meds that interfere less.
Exactly. You might use something like slow-release verapamil or hydralazine to bridge them. The key is to have that plan in place at discharge.
Okay, second major cause. Obstructive sleep apnea, OSA.
The prevalence here is just astounding. Between 25 and 50% of people with RH have OSA. The mechanism is this repeated hypoxia during sleep, which just cranks up sympathetic activation 24/7.
And since we can't get a sleep study in the hospital, what are we looking for?
We use screening tools like the STOP-Bang questionnaire, and you look for clues on exam: a large neck, a high Mallampati score. If you had an ambulatory BP monitor, you'd see they lose that normal nighttime dip in blood pressure.
And treating the OSA with CPAP can actually lower their blood pressure?
It can. Consistent use of CPAP can drop the blood pressure by 10 millimeters of mercury. It's a non-drug intervention that can make a huge difference.
Number 3 is chronic kidney disease, or CKD.
This is actually the most common secondary cause overall, about 14% of cases. And it's that bidirectional problem. CKD causes RH by impairing sodium excretion, and the RH then makes the CKD progress faster.
And finally, renovascular disease.
Right. Atherosclerotic renal artery stenosis. You should think about this in older patients with widespread atherosclerosis. The clues are an abdominal brute, maybe some unexplained hypokalemia, or that classic story of an acute kidney injury right after starting an ACE inhibitor or an ARB.
Okay, so after all that workup, we're ready to optimize their chronic medication regimen. This is really our main job in the hospital.
It is. You start by making sure they're on that foundational 3-drug regimen: an ACE or an ARB, a calcium channel blocker, and a diuretic.
And the first big move for a true RH patient is often to optimize that diuretic.
This is such a high-yield intervention. You need to replace short-acting thiazides like hydrochlorothiazide with long-acting thiazide-like diuretics, so chlorthalidone or indapamide.
What's the rationale there?
It's all about pharmacokinetics. They have a much longer half-life, so you get smooth 24-hour blood pressure control instead of the peaks and valleys you get with hydrochlorothiazide.
And what kind of BP drop can you expect from that switch alone?
It's significant. The data shows switching from hydrochlorothiazide to chlorthalidone can lower systolic blood pressure by an extra 7 to 8 millimeters of mercury. That's a huge win for just changing one pill.
Now let's circle back to that EGFR cutoff of 40 to 45 we talked about earlier.
Right, so the traditional teaching is that below that threshold, you switch to a loop diuretic like furosemide.
But some newer data has challenged that a bit, hasn't it?
It has. The CLICK trial was a big deal. It showed that chlorothalidone can still be effective even down to an eGFR of 25 to 30. So we may not have to abandon it quite as early as we used to think.
That gives us some flexibility, but what about in severe CKD or patients with hypobuminemia?
In those really volume-overloaded patients, predictability is key. I'd lean towards a long-acting lip diuretic, like torsemide over furosemide.
Why torsemide?
It has much better and more reliable bioavailability, 80 to 100%. Furosemide's absorption can be really erratic, especially if the patient has gut edema. With torsemide, you know what you're getting.
So if the patient is still resistant on that optimized 3-drug regimen, we move to the fourth line. And this is the cornerstone of RH management, the mineralocorticoid receptor antagonists.
This is the key. It's the step that directly targets the aldosterone excess pathophysiology. Spironolactone is the go-to agent, usually started at 25 milligrams a day.
And the evidence for spironolactone is really strong.
It's incredibly strong. RCTs show that adding spironolactone drops the 24-hour systolic BP by an extra 6 to 9 millimeters of mercury compared to placebo. That's often better than what you get from adding a fifth-line agent like a beta blocker or an alpha blocker.
The big barrier, of course, is the side effects, hyperkalemia especially.
Hyperkalemia is the main concern, particularly in patients with CKD or diabetes. Most of the trials restricted its use to patients with an eGFR of 45 or higher. You have to monitor potassium and creatinine closely, like within 3 to 7 days of starting or changing the dose.
And then there are the anti-androgenic side effects.
Right, gynecomastia in men. That can be a deal breaker for a lot of patients, with intolerance rates up to 40%.
So if a patient can't tolerate spironolactone, what are our MRA alternatives?
Amiloride is an excellent choice. It's a potassium-sparing diuretic, and it's been shown to be just as effective as spironolactone for RH, but without the anti-androgenic side effects.
And what about eplerenone?
Eplerenone is more selective, so it also avoids those side effects, but the data just isn't as robust. At standard doses, it doesn't seem to lower the 24-hour BP as much as spironolactone does. You might need higher doses.
And we should mention finerenone, the newer nonsteroidal MRA.
Right. Its main role right now is for patients with CKD and type 2 diabetes because of its proven renal and cardiovascular benefits in that group. Its role in just general RH is still being worked out.
So if a patient is still uncontrolled after an MRA, we're now in true refractory hypertension territory. And the strategy shifts to targeting that sympathetic drive.
Exactly. This is where you might consider a beta blocker, especially if their heart rate is consistently over 80. That high heart rate is a clue that there's a big sympathetic component.
What about central agents like clonidine?
If you're going to use one, the transdermal patch is much preferred over the oral tablets.
What is that?
The patch gives you smooth, consistent delivery. With the oral tablets, if a patient misses a dose, you can get severe rebound hypertension, which is really dangerous in this population. The patch is just safer.
And for the absolute toughest cases, there's always direct vasodilators, like hydralazine or minoxidil.
These are very potent, but you have to use them correctly. They cause so much vasodilation that the body fights back with reflex tachycardia and major fluid retention. So you must use them with a beta blocker and a potent loop diuretic. It's a package deal.
And what about the new agent, aprocitentan?
It's a dual endothelin receptor antagonist. The data shows it can lower systolic BP by another 4 to 6 millimeters of mercury when added on. But its main side effect is fluid retention and leg edema, so you have to watch volume status carefully.
Okay, let's pivot now from chronic management to acute crisis management in the hospital. The distinction between asymptomatic high BP and a true hypertensive emergency is critical.
It's everything. It's the difference between an oral pill and an IV drip. If a patient has an elevated BP, say, over 130 or over 80, but has no signs of acute target organ damage, you treat it conservatively.
So that means optimizing their oral meds, managing their pain, checking their volume status.
Exactly. You have to be very cautious about reaching for IV meds in that situation.
Why is that? What's the harm?
Well, observational data is pretty clear that unnecessary IV use for asymptomatic severe hypertension is linked to higher in-hospital mortality, more acute kidney injury, and longer stays. The body often self-corrects. About 40 to 50% of these patients will have their BP come down on its own once their pain or anxiety is treated.
And dropping the pressure too fast can be dangerous.
It can cause hypoperfusion to the brain or kidneys.
Okay, but in contrast, we have the true hypertensive emergency.
Right. That's a severe BP, over 180 systolic, with evidence of acute organ damage. That requires immediate IV therapy, preferably with a short-acting, titratable, continuous infusion.
And the BP target here is not on 30/80, it's highly individualized.
It depends entirely on which organ is being damaged. The AHA has very specific guidelines for each scenario.
Let's run through the big ones. Acute aortic dissection.
This is a true emergency. The goal is to get the systolic BP to 120 or less within 20 minutes. You use agents like esmolol or labetalol. And the absolute critical rule is that beta blockade must come before any vasodilator.
Why is that so important?
Because if you vasodilate first, you'll get reflex tachycardia, which increases the shear stress on the aortic wall and can make the dissection worse. You have to control the heart rate first.
Okay, what about acute pulmonary edema?
Here you want to reduce both preload and afterload, so something like clevidipine or nitroglycerin is a good choice. And you generally avoid beta blockers because they can worsen the heart failure.
Acute ischemic stroke, but the patient is not getting thrombolysis.
This is permissive hypertension. If the BP is below 220 over 120, you generally leave it alone to maintain perfusion to the brain. If it's higher than that, you layer it by only about 15% in the first hour.
And there's a specific drug to avoid here.
You must avoid hydralazine. It's an unpredictable vasodilator and can actually increase intracranial pressure in this setting, which is the last thing you want.
And is that the same rationale for avoiding it in acute intracerebral hemorrhage?
Yes. For a brain bleed, the goal is to get the systolic down to the 140 to 150 range within an hour. You don't want to go below 140, and again, no hydralazine due to the risk of raising intracranial pressure.
And finally, hypertensive encephalopathy.
The goal is a controlled, steady reduction. Lower the BP by about 20 to 25% in the first hour, then aim for 160 over 100 over the next several hours. Labetalol and nicardipine are great choices here because they're so titratable.
Okay, let's round out our deep dive with non-pharmacologic strategies and a few special scenarios. The lifestyle piece is so important, especially for a volume-driven disease.
They're not just suggestions, they're active treatment.
Right.
They can lower systolic BP by about 5 millimeters of mercury on their own, and they make the drugs work better. And the most important one for RH is sodium reduction.
How big of an effect does that have?
It's huge. A 1,000 milligram reduction in sodium intake can lower systolic BP by about 3 millimeters of mercury. For this population, the goal should be less than 1,500 milligrams a day. It directly attacks the volume problem.
And then there's weight loss and potassium.
Right. Weight loss gets you about 1 millimeter of mercury per kilogram lost. And potassium supplementation helps too, but you have to be really careful in patients with CKD or those on an MRA because of the risk of hyperkalemia.
Let's talk about that really challenging group, patients with both resistant hypertension and chronic kidney disease.
Yeah, this is where RH is most common and hardest to treat. The prevalence of true RH in CKD is almost 23%, more than double the general population. The kidneys just can't handle sodium, so they're massively volume expanded.
And this is where we might need advanced strategies like sequential nephron blockade.
Exactly. This is for the most volume-overloaded CKD patients. You use multiple diuretics that work at different parts of the nephron to overcome the kidney's ability to compensate. So you might use a loop diuretic, a thiazide-like diuretic, and an MRA or amiloride all at the same time.
And what about diabetic patients and MRAs?
They are a group that should be strongly considered for MRA therapy, especially if they have albuminuria, because of the known kidney and heart protective benefits. But the hyperkalemia risk is even higher when you add an MRA to an ACE or an ARB in a diabetic patient. So that close monitoring, checking labs within a few days, is non-negotiable.
We can also use renin and aldosterone levels to personalize the therapy.
This is a really elegant approach.
Yeah.
If both renin and aldosterone are low, it's a pure volume problem. The treatment is a low-salt diet and maybe amiloride. But if renin is low and aldosterone is normal or high, that points towards autonomous aldosterone production. And an MRA is clearly the right mechanistic choice.
Lastly, what's the current thinking on renal denervation, or RDN?
Well, the idea of ablating the renal sympathetic nerves is appealing, but the clinical data has been a bit underwhelming. The trials show a modest blood pressure reduction of only about 3 to 5 millimeters of mercury over a sham procedure.
And there are some important limitations to those trials.
There are. They excluded patients with isolated systolic hypertension and, importantly, anyone with an eGFR below 40. We also have no long-term cardiovascular outcome data. So right now, it's not a cure, and it's not a replacement for medication. It's maybe an option for a few very select, truly refractory patients.
This has been a really comprehensive roadmap. The hospital stay is such a key opportunity to get this right.
It is. So to summarize the key takeaways, First, your main job is to rule out pseudoresistance. That means optimizing the diuretic, switching to a thiazide-like agent, or using a loop if the eGFR is low and hunting for nonadherence and interfering drugs like NSAIDs.
Second, once you've confirmed true RH, your fourth-line agent should be a mineralocorticoid receptor antagonist spironolactone or amiloride because you're directly treating the underlying pathophysiology.
And third, in the acute setting, be extremely cautious with IV meds for asymptomatic high BP. Reserve continuous IV therapy for true hypertensive emergencies, and tailor your drug choice to the specific organ that's being damaged, like avoiding hydralazine in any kind of stroke.
We spent a lot of time drawing that line between volume and aldosterone-driven resistant hypertension and the sympathetic-driven refractory type. So that brings us to a final provocative question for you to think about. Since that overwhelming sympathetic drive is what defines refractory cases, the ones that fail even MRA therapy, how should we be systematically screening for and addressing that heightened sympathetic activation beyond just looking at the heart rate? What are the next level biomarkers or clinical clues we should be using to guide our choice of sympatholytic drugs to move from just titrating to truly targeted neurohormonal blockade?
Thank you for joining us for this deep dive into resistant hypertension.